Welcome this morning our guest speaker, Dr. John McNeil. Dr. McNeil currently serves as the Sir John Monash Distinguished Professor in the Department of Epidemiology and Preventative Medicine, and also medical faculty at the School of Public Health and Preventative Medicine at Monash University, all the way over in Australia. So he's traveled quite a distance to speak with us today. He received his medical degree in training at the University of Adelaide and completed a fellowship of the Royal Australasian College of Physicians. He then went on to receive his Master's of Science in the Department of Medical Statistics and Epidemiology at the London School of Hygiene and Tropical Medicine. He also went on to earn his PhD in Clinical Pharmacology and Therapeutics at the University of Melbourne Austin Hospital, and then was a fellow of the Australian Faculty of Public Health Medicine. As you may be picking up on, his career focus has been in the fields of public health and preventative medicine, and during his career in medicine and research has received over 150 grants since 1994. Just this year, he received over $42 million in funding from the National Institutes of Health for his project titled Aspirin and Reducing Events in the Elderly Extension. Furthermore, given these significant contributions, he was awarded the Order of Australia in Australia Honour Days, or Australia Day Honours, which is given to an individual recognized for their distinguished service of a high degree to Australia and humanity at large. This was also, he was also noted to receive and be recognized by Monash University for a Lifetime Achievement Award. So for a gentleman who's spoken all over the world on his research throughout his career, we want to welcome Dr. John McNeil to the stage. Thank you.
Oh, thank you, Joshua. What a kind introduction. I'd like to say what an honour it is to be here, and how wonderful it is to catch up with Jeff, who's been such a wonderful collaborator in our Esprit project, and also to Ray Velez, who studied epidemiology with me about 35 years ago. So there's several reasons why I'm absolutely delighted to be here in Wake Forest. I'm going to talk a little bit about aspirin for prevention of cardiovascular disease, lessons for prevention. I've got no relevant disclosures, and I just want to talk to you briefly about what I'm going to be talking about. Firstly, about the changing perception of aspirin, then about some remaining questions about aspirin use, and thirdly, some lessons that we gain from this, more general about drugs and prevention. Now, I'm a great believer that if anyone takes away one single fact from a lecture, that I have done a good job. And the one fact today is not that aspirin is a wonderful drug for the elderly. I'm going to talk particularly about a series of papers which Jeff and I were both co-authors on, which were published in the New England Journal about a year ago now. All of them were a report of a clinical trial that we'll be talking to you about. One of which suggested that aspirin did not improve healthy lifespan. The second, that it had little effect on cardiovascular disease or ischemic stroke. And the third, that it actually increased rather than decreased mortality. Now, the question is why, I guess, we set up this study, which was a very big undertaking. And I guess the first question is why study aspirin? I'm a clinical pharmacologist by background, and my friends have always said to me, surely you could have found something more interesting. Have you heard of PCSK9 inhibitors and things? But in actual fact, aspirin is a very important drug because it is used so extensively by so many millions of people. In the US, I understand that about 38% of elderly people take aspirin routinely. It has a very logical mechanism of action because it inhibits platelet aggregation, which is believed to underpin so many conditions of ageing. But in the elderly, there's also an exponentially increasing risk of hemorrhage with aspirin. and nobody has successfully managed to work out what the balance is between the good and the bad things that aspirin does in older people. And moreover, since about 2000, there's been some important negative trials. So it was a question which was begging to be answered. We'd actually identified the fact that this was a big, important question of medicine back in the early 1990s, where we published a couple of papers pointing out that this was a big evidence gap in medicine. But it took about 15 years or so, nearly 20 years in fact, before we could raise the money to actually do a study to test and establish what the proper risk-benefit was. The second issue, which is important, is why we use disability-free survival as an endpoint, because nearly all big clinical trials, as you know, with aspirin and other cardiovascular drugs, use a cardiovascular endpoint, not disability-free survival. Disability-free, this was the first large mortality morbidity study which used disability-free survival. But there were two reasons we chose this. Firstly, it's the fundamental purpose for a preventive drug in the elderly. If you're giving a preventive drug and it doesn't improve your healthy lifespan, then why on earth take it? But the second thing is that it integrates the positive and negative effects of a drug. And many of the clinical trials of aspirin in the past had come to a conclusion like, this reduces myocardial infarction by 3%, but increases bleeding by 5%. Well, what does that mean? How could we balance those two? And yet disability-free survival integrates the positive and negative effects and does indicate what the net effect of a drug is. Now, ASPREE was a study which was done right across Australia and the US. There were a number of sites in the US, but the principal sites were in Minneapolis, here in Wake Forest and in Philadelphia. It was a simple study. We just randomised people to 100 milligrams of of aspirin and placebo. All of the people were aged 70 or above, except a small subgroup of minorities. And there was an average of 4.6 years of follow-up, interestingly enough, until the sponsors, the NIH, told us to stop because they felt that progressing any further was futile. Doing clinical trials of a very large numbers of people in this age group is very challenging. We were very successful in the Australian arm in recruiting people from country towns, but we had many, many meetings like this. We're inviting our participants in various country towns to morning teas where we told them about the importance of the study, and these went on annually to keep people involved because, of course, in a person's 70s and 80s, there's a lot of things that go wrong. Close people die, people get depressed, and keeping people enthused and stopping a dropout is a massive challenge. So this is two graphs which illustrate the main results of ASPREE. I think I'll just show you this one first because it shows the progressive increase in bleeding. This is a cumulative incidence plot. Along the bottom here are the years of engagement in the study, and up here is the percentage of people who've actually met, in this case, the endpoint of bleeding. And the red line is aspirin, the blue line is placebo, and you can see that as aspirin, as the years progress, these lines diverge, indicating that aspirin has a continuing, causes a continuing risk of bleeding in this age group. And I'm showing you this first because it proved to our satisfaction that people were actually taking the drug. And that's, of course, a very important issue with clinical trials. But this is the cumulative incidence plot for disability-free survival. And it is hard to imagine a drug which could have had less effect on disability-free survival. Now, those lines almost perfectly overlap. And that was what we published in the first of the New England papers. Now, people said straight away, oh, but look, this is 19,000 people. There must be subgroups here who benefit from aspirin. You just have to find them. Well, we looked very carefully, And we looked at, these represent, I'm sorry, it's very difficult to read, but they represent a whole range of subgroups ranging from diabetes, people who smoke cigarettes, the Australian, the US populations participating, people of high body weight. But you can see, I think quite clearly here, that there are no subgroups that stand out as having benefited. And this, I think, solved another question. Now, when I was a lecturer in clinical pharmacology, one of the things I felt most certain about, and I taught a generation of students in Melbourne, was that aspirin reduced the risk of myocardial infarction by about 25%. It also reduced the risk of ischemic stroke by about 25%. Well, after looking at this, I felt I should write to all of them and explain my regret. Because aspirin did very, very little to fatal and non-fatal myocardial infarction, and very little to stroke. Maybe a 10% reduction in ischemic stroke, but certainly that didn't come close to clinical significance. And that was, again, a surprise. But the biggest surprise in ASPREE was this. This is the all-cause mortality. And you'll see in the same graph as I've shown before that the placebo group and the aspirin group tracked together till about 3 years, and then the aspirin group started to have more deaths than the placebo group. And this was statistically significant. When we had a look at what the cause of these deaths were, it was nearly all caused by cancer, which completely took us by surprise because we had no idea that this would happen. And during the course of ASPREE, there were a lot more cancer deaths and cardiovascular deaths. We had 1,052 deaths amongst these 19,000 people followed for nearly 5 years from any cause, and 522 of them were from cancer, and 203 were from cardiovascular disease, which I think partly reflects the very healthy nature of this population, but also reflects the fact that cardiovascular disease is well treated, and cancer is a very dominant cause of death now. Very few died from hemorrhage. Now, I don't like showing tables, but this one is important because we obviously had to look at the cancer results very carefully, and we've just sent off a publication looking at this. But the summary with cancer here was firstly that there was a statistically significant increase in cancer deaths, that just about every site of cancer had slightly more deaths on the aspirin arm than in the placebo arm. So, for example, there were 55 deaths from lung cancer in aspirin, 51 in placebo, 35 colorectal in aspirin, 20 in placebo, and so on and so on. In other words, just about every different site of cancer had just a few more deaths. And they added up to 290 deaths, 5 deaths from cancer at any site versus 227, which was statistically significant in an unadjusted statistical analysis. And that's quite important, as we'll see in a minute. Now, the conclusions which we published in these papers were firstly, aspirin use in healthy people did not prolong disability-free survival over a period of 5 years, nearly 5 years, but led to a higher rate of major hemorrhage. That was paper 1. Paper 2, the use of aspirin did not result in a significantly lower risk of cardiovascular disease than placebo. And thirdly, and this was the important one, higher all-cause mortality was observed amongst apparently healthy older adults and was attributed primarily to cancer-related death. In the context of previous studies, this result was unexpected and should be interpreted with caution, which I think is a very reasonable conclusion given the fact that this was the first study to identify a result like this. It may have just been because this is an issue which is restricted to older people. It may possibly be due to chance. Nobody could deny that. But I think what's so important here is that it's a safety signal, and this study's unlikely to be repeated, and we're probably likely to have to work out what to do about aspirin in the future on the basis of these results, because it's unlikely that another study like this will be done in older people. Now, naturally, the results of ASPREE gained a lot of publicity, much more than I think any of us have anticipated. There were 17,000 media mentions and lots of press. And the managing of the message here became really important, because we had to consistently point out that we were talking about the use of aspirin for primary prevention. And it was very easy for this message to get to drift across and cast doubt on the use of aspirin for secondary prevention. And we did our best to stop this happening, that this is a primary prevention result. People who've got cardiovascular disease or so on shouldn't take notice of this. They should continue. Interestingly enough, the immediate impact of papers these days is measured by the altimetric score, and the 3 New England Journal papers were all in the top 100 of the 2.5 million medical publications in 2018. Now, one of the things which gave us a lot of some confidence in the ASPREE results was the fact that it was one of 3 very large clinical trials of aspirin in primary prevention, all of which had been set up because of the doubt that I'd expressed earlier. One of them was the ARRIVE study, a European-US study published in the Lancet. It was in moderate cardiovascular risk people who were on average about 10 years younger. It had a cardiovascular endpoint, and there was the ASCEND study published in the New England Journal just about the same time we did in type 2 diabetes in a large number of people as well, again about 10 years younger. And all of them were community-based trials. All of them used 100 milligrams a day, not the baby aspirin that's of 80 that you use here, but just about all aspirin trials use 100, and all were placebo-controlled. Now, the ARRIVE study, again, this is the one in moderately elevated cardiovascular risk, the sort of typical person you might see in their 50s or their 60s, who've got a number of other risk factors. 29% were smokers, half of them had high LDLs, and a lot had hypertension. They were followed up for 5 years. They had a composite cardiovascular outcome which looked almost the same as ASPREE did. Again, almost nothing for a composite, and yet the only statistically significant result was an increased bleeding risk. And so again, this paper came to the conclusion that aspirin had no benefit except increasing GI bleeding. And then there was the ASCEND study, which was slightly different. This was an interesting study because it was conducted largely by male, a much less expensive study than what Jeff and I were doing. 15,000 UK participants followed for 7.4 years. They had a protocol change halfway through the study where they weren't getting enough endpoints, which is a very common problem here, so they added TIAs. And it was largely because of the addition of TIAs that they actually started to get, they got a statistically significant result for serious vascular events. But again, it was only about a 10% reduction. Very much, just almost the same as what we had for ischemic stroke. And their conclusion in their paper was that the absolute benefits were largely counterbalanced by the bleeding hazard. And not only that, the advantage they did see in diabetics was restricted to the first 2 or 3 years of the study. So again, not even in diabetes. So in the 3 big risk areas where you would imagine that aspirin would have a big effect, in the elderly, in diabetics, and in people with other risk factors, the results were basically negative. Now, these results, of course, have been put through various meta-analyses, and one of these was published last year. And the result which I've just extracted here is for fatal and non-fatal myocardial infarction. And it again settled out at about a 10% reduction. But what's a 10% reduction in myocardial infarction nowadays compared with 10% 30, 40 years ago when I graduated? And people who had a myocardial infarction often had a large amount of cardiac damage and progressed to cardiac failure. Well, these days I don't think a majority of non-fatal myocardial infarctions is anything like that. People are stented, they go out of hospital 2 or 3 days later, and I don't think that this represents a massive benefit, but we can debate that. So the conclusions, I think, from these 3 studies are firstly that there was little or no benefit from aspirin seen in the groups most likely to benefit, certainly in the elderly, and in ASPREE that finding was totally unambiguous. I don't think all of us worry about doing big trials where there's an ambiguous finding, but in ASPREE I don't think there was any ambiguity at all. Aspirin did no good at all and was probably harmful. There was a signal for net harm in the elderly. There were no subgroups with net benefit yet identified. There was a small but non-sustained benefit in CVD in the diabetes trial, and there was an ongoing risk of serious bleeding, which was interesting because some people have written in the literature that the bleeding risk of aspirin is just a short-term thing, and if you recover, well, it's clearly not. It clearly continues. So we were very pleased when the American College of Cardiology, the AHA guidelines, came out earlier this year, and they made the statement, low-dose aspirin should not be administered on a routine basis for the primary prevention of cardiovascular disease amongst adults 70 years of age, and they put a harm recommendation here. And I think that was very gratifying for us because it meant that a clinical trial was translated very quickly into the guidelines which people follow. The others I won't go into, but they've also cast a lot of doubt on aspirin use. Now, the one thing though that's a problem with aspirin comes from a paper that was published in 2010, where in the UK they followed up people whose names and addresses they'd got who'd participated in early aspirin trials. And over there they're able to match them later on against the National Death Index. And they found that after the period of intervention in a trial, after the 4 to 5 years that a typical trial goes on, if they followed those people post-trial, then gradually there seemed to be a protection against cancer death. And that progressed out to about 9 or 10 years here, but in other papers they'd progressed it out to 20 years. So there was this, I guess, this very strong suggestion that the results that one sees in terms of cancer is a preventive effect which becomes greater after aspirin stopped and progresses long into the future. And that has caused our results caused some consternation because they showed that an early problem with cancer. And so that's why the NIH has funded Jeff, myself and our ASPREE colleagues to follow our ASPREE participants further into the future to see if our cancer result is going to turn around and resemble this. Because this finding has been incorporated in quite a lot of cancer prevention guidelines now, including the ones in Australia. So there are some remaining questions with aspirin. Should a person who's been taking aspirin for the last 20 years and is, say, 75, should they stop it? A very common clinical question. Well, we didn't study that question. Nearly everyone in ASPREE started aspirin afresh. There are about 10% who'd been on aspirin in the past who showed no difference in their main effect, but that's not enough to answer that question. And so at the moment it's unclear, and some of you may be aware of a question and answer in the New England Journal which asks people whether they'd stop, and the doctors whether they'd stop aspirin, and it was about a 50-50 split. Are there subgroups still to be identified where the benefit of aspirin outweighs the risk? Well, we just don't know. I don't think they're likely to be, but we need to look at our lipids, our biochemical profiles, and all sorts of things to see if we can find it. Is there any relevance for secondary prevention in old people? Well, I think in this day and age that's an important question. We, as I said earlier, said yes, if you've had a previous infarct or a ischemic stroke or TIA, definitely continue. But I'm not 100% sure where the risk-benefit lies in older people. And I think this is going to be an important follow-up study. But then the last question is, should aspirin be avoided in older people after a diagnosis of cancer? And I think that is the one question which we're really struggling with at the moment, because from what I've seen of our data, if I had cancer, I think we'd have to seriously wonder about that. So these are the remaining questions. And then there's the issue of, well, what does Esprit, what do the results do for drugs in prevention in general? Now, Ray and I when we both studied epidemiology many years ago, worked with a man called Geoffrey Rose, who was a very well-known cardiovascular epidemiologist, who drilled into our heads that doctors have a natural tendency to overestimate the benefits and underestimate the risks of preventive drugs. And I think that's probably true. I think for most doctors it's in their DNA. But, of course, when we use a drug for prevention, clinical intuition means nothing. It's all about the maths. And and the first principle, of course, is that we have to treat a lot of people for a long time to save a minority. And in Esprit, after we followed up these relatively older people for 5 years, only 10% of them had died or become disabled. We were hoping that we'd have a 15% reduction. But even if we found this 15% reduction, and we didn't find any reduction, it would have still reduced the 10% who died or became disabled to 8.5%. So we would have had an absolute reduction of 1.5% over 5 years. And that is a lot of people to be giving aspirin to save a few over quite an extended period of time. But then the other thing which Geoffrey Rose pointed out, and which has been proven true time and time again, that when you have a small benefit like this, the benefit can be negated by a tiny risk that's detectable only with a large clinical trial. And there is no doubt that the mortality risk and the cancer risk would never have been identified except for a clinical trial of this size and type. Now, there was an interesting paper recently which pointed out that innovations to looking at new drugs which might retard ageing is a very big growth industry in the pharmaceutical industry. They're studying things from telomere attrition to drugs which might stop the chromosomes degrading and so on. And quite a few of these are in clinical trials. But I think Esprit was demonstrated to us that before these become mainline, they're going to have to be put through big studies like this to work out the risk-benefit balance. And I think that the Esprit study, and I think the SPRINT study that Jeff recently published, and the new statin study which is being set up, are providing us with the ability to understand how to actually do these studies and do them efficiently and quickly. Now, studies like this require a big workforce. Over 100 people were employed in the Australian arm of Esprit, and they're mainly young women like this, and they were supervised by Associate Professor Robin Woods here, who we were very proud enabled the study to come in on time and on budget, which our funders really loved. And what was interesting is how hard it is to maintain maintain the enthusiasm of those young people, because when they're doing a study like this, they get very attached to the old people who are the older people in the study, and so many of them become depressed. They lose their spouse, whatever, and it has a very big effect on them. And a lot of work was needed to be done with counselling and so on during the course of this work. I was very grateful for the steering committee. I was the coordinator at Monash in Australia. Richard Grimm was the original coordinator. He'd been involved in a lot of big studies. And of course, Jeff and Anne Newman and a number of others from the US were wonderful colleagues, and this worked together really well. So I'd like to just finish with a little quote from a chap called Josh Billings, that wisdom don't consist only in knowing more that's new, but knowing less that's false. And I think that this particular study exemplifies that fairly well. So thank you very much for listening.
All right, do we have any questions?
Thank you very much for the excellent lecture. I'm a medical oncologist, and I deal with secondary prevention. I don't see the patients in my clinic to consider using aspirin before a history of colon cancer. And in our literature, we quote the Norway study published in JCO in 2016. More than 20,000 patients after previous history of colon cancer. They have a registry in Norway that you may be familiar with that actually in the prescription to get aspirin. So that's increased the compliance. And also the colonoscopy is routine and was following these patients, no imbalances. So the incidence of polyps, the incidence of secondary cancers, and the incidence of cancers diagnosed at an early stage, all benefiting the aspirin arm. So for secondary prevention, more than 20,000 patients, we routinely in our clinic recommend a baby aspirin. What is your take on that?
Are you referring to Lynch syndrome, or are you referring to a wider use?
So there were patients with hereditary colon cancer were excluded in that database, but only patients without any of the non-hereditary risk for colon cancer.
Look, there's no doubt that there's been some very convincing studies of polyps, and in Lynch syndrome there seems to be a protective effect. But most of those studies are done in much younger populations, and I have tried to really emphasise here that this is an elderly population. And at the moment, there's, for exactly the reason you said, there's two big studies going on, one by the Medical Research Council in London and one funded by the NIH in breast cancer, looking at aspirin as an adjuvant to treatment after a diagnosis of cancer. And in our paper, which we hope will be published fairly soon, we've emphasised that this must have enough elderly people in it to be able to answer the question, confirm this or refute it. And at the moment, we don't think there are.
That's something that I struggle with. Age is more biologic than a number. So if I practiced in Florida for 14 years, and you're not old in Florida until you can't not do anything. So I'm 100 years old. That is different. And I'm originally from Brazil, where 6 years old, you're old. And physiologically, having being a Brazilian, it's not infrequent to see that you have much more comorbidities in those elderly patients in Brazil than in Florida, for example. So the question is, should we use more of a biologic aging rather than just cut off at 70 like many of the trials?
Look, that is a bit outside my competence, I'm afraid. All I can tell you is that this is what we found in our over 70s, and it was a very consistent finding in various subgroups. and without any adjustment, it was statistically significant. Really have no idea. We assume it's age, but we have to look at the adjuvant trials and just make sure they have enough old people.
I should know the answer to this question, and I don't. So the question, Dr. Neal, is this. Aspirin for secondary prevention in people over the age of 70 to 75, what do the data show if there are good data?
There hasn't been a secondary prevention trial, a new secondary prevention trial done for many years, Bill. And these days, the mortality from cancer, from cardiovascular disease, from an infarct, is so much lower that the question is, well, how does the risk-benefit weigh out in the people over 70? And I don't know, but I think that's the next big study which needs to be done.
The other question? Okay.
Thank you for that great talk. Some years ago, I was in New Orleans, and there was a cardiovascular conference, and they had a machine that I've never been able to find clinically available that showed 25 to 30% of people were insensitive to the platelet disaggregation effects of aspirin. And I called up to the Cleveland Clinic, but I've never seen that. Is there some thought about a certain percentage of the population simply aren't sensitive to aspirin's effects at any dose?
Yes, that's an interesting question. We were in a very fortunate position that we collected blood and urine before people went on to aspirin and 3 years into the study. We haven't raised the money yet to be able to analyse the particular compound which demonstrates an effect of aspirin, but we certainly plan to do that, and that is a possible explanation. The only thing I would say, though, is that the bleeding risk here was so elevated that we know that aspirin was having an effect.
Wanted to ask about, using the outcome of disability-free survival, and especially when applied to older adults. One of the things, obviously, I work with Jeff on a number of trials, is that getting things like dementia and cognition is really, really hard, right? If it's an MI, there's a hospitalization. And I'm curious if you have any lessons from Esprit of, are there better ways we can do that to try to ascertain these things more efficiently? Because currently it's very difficult and really, really expensive.
You're absolutely right. When we first put up Esprit, the plan was to use the surrogate outcome of entry to residential care. But that was judged to be not enough, and so we introduced cognitive tests on all 19,000 people, which were done every 2 years, and that is very expensive. And there was a range of those, and everyone who had a fall in their MSE less than 78 and so on went on then for a dementia follow-up. It really took it out of us, and the participants didn't like it. And Jeff was telling me last night that you're using a new innovation with the preventable study, and it'll be terrific if that turns out to be better.
Okay, thank you for your presentation. This is, and I think Jeffrey Rose would be so proud and is celebrating somewhere in the cosmos for your presentation. People don't realize that we've turned the world upside down on primary prevention, the use of aspirin with this trial. It's a randomized controlled trial, the highest level of evidence that we can produce. Is there any room for cohort studies or observational studies?
That's interesting. When we sent this up, proposed this to the New England Journal, Ray, we had a paragraph in there about the cohort studies and what they'd showed. And the first iteration, they said, get rid of this. We don't believe in cohort studies. So we expunged it. But, obviously there's some things which we can't randomise.
I have a question. Thank you for your talk. I had a question about secondary prevention. If you look at like the Capri trial where they're comparing clopidogrel versus aspirin, they actually saw a lower bleed risk. And one of your points was with primary prevention, like it's not worth it because the bleed risk is there. The cancer is more of a question mark. So I just haven't seen a lot of that in clinical practice where people are like, well, aspirin for elderly, maybe the bleeding risk is too high. Maybe we should switch to clopidogrel.
Yes, look, I can't really comment on that, I'm afraid.
Thank you.
John, that was an absolutely fantastic talk. I was wondering, so the secondary prevention trials, go back, quite a ways. Did any of those trials, look at incidence of cancer, as an endpoint? And, if not, what's the possibility of, trying to go, reconstitute those cohorts and following them, over time to see if you could, pick up some kind of signal in those studies? And even, the studies that may have compared, lower and high dose aspirin, if there's any suggestion of a dose response.
Yes, I think that's a good suggestion, Gary. I'm going to. You can do this in the UK, of course, because and I should just point out that the studies which looked at the cancer prevention were a mixture of primary and secondary studies, but nothing that's been published. And remember, all these studies are in younger people, and none of them identified the same cancer risk. But one of the things which I didn't mention, which I think is important, is that death is such a definitive endpoint that there's no question that we got that wrong. And the second thing is that the cause of death is pretty clear-cut too, and we didn't make a mistake. There is no bias in the fact that we identified that these people had died of cancer. The big question was, did aspirin perhaps increase their bleeding, cause death by increasing bleeding? And we went through every cancer death and we found that only a tiny number had bleeding at the end. And in the paper, which we hope to publish fairly soon, we're showing that not only did aspirin increase the deaths from cancer, but it also increased the number of cancers presenting at an advanced stage. So it's a very compelling story, in my view, about aspirin in older people. And whatever it is, it's a signal which could be very important considering the number of people who are taking this drug. In 50 countries around the world, remember, Bayer has told us that there's an indication for aspirin, not for primary prevention. So, this is a question which will impact millions of people.
Thank you. That's absolutely fascinating. It's a fabulous story, and we talked a lot yesterday about our common interests. But what I didn't mention was something else that I've continued to wonder about, because perhaps the placebo effect is really real. And when I was involved in Seattle in the coronary primary prevention trial, it was a 10-year study, reduced cardiovascular disease and deaths in middle-aged people and so forth. And it was first to show that cholestyramine could actually be associated with a reduction in cardiovascular death. And everything went on from there once we got statins on the market. But what was interesting, as I oversaw that as a Northwest Lipid Research Clinic in Seattle, it was a double-blind study. Nobody knew who was on what, including anybody on the staff. That was analyzed elsewhere.
But one of the things, it was a double-blind study with a placebo for the cholestyramine. And it was very hard and very laborious to do this for 10 years without knowing how it was going to come out. But one of the things they asked the subjects was whether they thought they were on the real drug or was on the placebo. And it turned out at the end, the people who felt they were on the real drug had a much lower incidence of cardiovascular disease than the people who felt they were on the active drug. So the belief, just like people who are on fish oil or something else, it may be a placebo effect, but maybe it has a real effect, particularly in older people. Is that possible?
Yeah, that's very interesting, Bill. It's one of the things which we did look at. We thought, well, even though they were identical, and we thought that may have happened, but when we did a question at the end of it and asked people what they thought, they were equal.
Good. I just want to say thank you. Most people don't realize also behind a big trial like this has to be a calm leader and who can withstand the storms that blow from the left and the right. And so I just wanted to thank you for that because it was a great example. I was thinking last night that the term gentlewoman or gentleman and scholar seems to be an anachronism today, but I think everyone in here should know that I think you're the prototype of that, so I just want to thank you for that.
Thank you, Chair.